right, so we're going to go ahead and get started on going over the PowerPoint Unit 2, the toddler. The goal is, I think, let's try and get through growth and development, and then we will be able to do poisonings on next Wednesday, and as well as reviewing the disease processes. So if we're going to go ahead and start out, we're going to look at just some physical signs of growth within this population. We're looking at anywhere between like a 15-month-old upwards to like a 3-year-old is going to be, again, the growth and development we're looking at. By this time during our physical assessment, we should be seeing that that anterior fontanelle is closed. One thing to keep in mind is all of those reflexes by now should have, the child should have outgrown those reflexes, like the extrusion reflex and things like that. However, what we're looking at now is this Babinski reflex. If the Babinski reflex is still present by the 2 years of age, this is very concerning, and we consider this pathologic or that there needs to be further investigation. This is not normal. So keep that in mind. If you're assessing a child when they come into a well-child visit, that Babinski reflex should be gone by 2 years of age. Also, what we're seeing in this development and growth is that they have kind of a bow-legged stance, which is really seen when you notice them walking. They walk kind of like a cowboy getting off a horse type thing, or really they look a lot like a person with hip replacements. They do kind of that side-to-side type walking. So they're absolutely mobile and getting into a lot of things and curious, but keep in mind that they do have an unsteady gait. We also notice some lordosis. Maybe you've kind of noticed that kiddo that their tummy's kind of sticking out. Again, keep that in mind when we look at these terms. Lordosis is that sway back. We also put this term with pregnant women, which is lovely. But again, you're going to notice that these kiddos, their tummies kind of stick out a little bit. Do review the vital signs, what's normal within this age category, with that same disclaimer that depending on which resource you're looking at, those vital signs are going to look just a little bit differently. What you're looking for is some common area or where they overlap. Your weight should be increasing at about 5 pounds per year. Length, this is kind of one of those things where everyone wants to know with their 2-year-old how tall they are, because then they try and figure out what they're going to be as an adult. I'm sure some of you ask your mothers. I'm sure that they did this for you as well and see how closely you came. But so if whatever your height is at 2 years is half of what your adult height should be. Again, just review kind of what normal growth and development is at this age. Here's a nice little picture of our little cowboy swaying along the sidewalk there. Immunization schedule. So this is going to be one where, and refer back to your CDC vaccination schedule, because that is the most up-to-date and recent. But around 15 months old, now you can see this anywhere from 12 to 18, they're going to be getting the MMR, varicella, DTaP, Hib, PCV, IPV, and Hep A. I'm not going to go into this on this lecture, as we're going to be going through that next time we meet. What this kiddo is able to do at 15 months old, should be able to walk alone, maybe not very steadily, but should be able to do this. Should have the dexterity to put something into a bottle, or to be able to pick up a toy and put it into a bucket. Should be able to stack a tower of 2. And when we start looking at language patterns, is very much able to understand what you're saying to this child, not as able to communicate. And this is when we start getting into these terrible 2s and 3s and the temper tantrums. Some of it is just the inability to express what they're trying to say, and they get very frustrated. We're right in the heart of that separation anxiety, so we'll be thinking about preschool and things like that. It's going to be very difficult. And then also when we look at our purview with these kids, taking them back for any sort of examination without the parent or hospitalization is going to cause some anxiety for this child. Still have some fears, and I know we kind of went backwards. So these fears that we saw in our preschool age child is beginning to materialize. So they again have this fear of being immobilized, They are absolutely going to ask you whatever you're doing if it's going to hurt, because they're very afraid that what you're going to do to them is going to hurt them, and that is a fear for them. And here we start seeing that fear of the dark. Up until this point, you might have been able to get away with putting the kiddo to bed without a nightlight. Now you're going to have to start putting a nightlight into that room. 18 months, we're getting a little bit more coordinated. We should be able to throw a ball overhand and possibly remove clothes. This is, again, another area where they're looking for some sort of transitional item or something that is a soothing, like a pacifier. So thumb sucking is at its peak, or for those kiddos with the pacifier. So just kind of keep that in mind. This is usually about the time when parents start to wean them from this, which is a little bit ironic. So kind of keep that in mind when you're dealing with a caregiver or a parent when they come in for a clinic visit. And just make sure that we're educating them on normal growth and development. Is beginning to know boy or girl, who's boys, who's girls by looking at them, understanding that there is a difference. Very much likes to imitate what they see. So again, this is kind of a fun time where they may see mom sweeping, and so they decide that they need to also sweep, folding clothes, putting things away. Keep in mind it is not done at a high level, so whatever they're doing you're probably going to have to redo, but it is a really good part of their development, and when we start looking at Erickson's, it's a really important milestone for them. Should be able to name one body part and say about 7 to 20 words. So just kind of rule of thumb when we start looking at what they can do dexterily, and also kind of how to memorize these milestones or a guideline about their age. 1 year, 2 year, 3 year is about, again, going to be how many, if we go back there, 1 body part. 2 should be able to say about 2 to 3 body parts. So again, it's just a little rule of thumb there. 24 months can be a particularly fun time in the development because these kids are becoming more and more active, and it's really, they're learning and doing a lot of things. So there's a lot of firsts in this age group. However, it's a dangerous time as well. So parents really need to be advised that as they, again, that's anticipatory guidance, as their child gets older, we need to be identifying, hey, understand that that door that they weren't able to open, now they may be able to. So if it's an outside door or a door to the basement, keep that in mind. Poisoning, which you guys are going to educate all of us about, is a big one, and this is because they're able to start getting into these things. I think it's really interesting that now you see on commercials the little laundry packs and the dishwasher packs. They're so great, right? You throw one into the laundry washing machine and everything is all packaged neatly. Perfect for little kids to get into and pop right into their mouth. So I thought it was very interesting that they now have a whole commercial advising parents against that. So again, a very fun, exciting time for both the child and the parents, caregivers, but also definitely a time where safety is going to be a #1 priority. They're starting to put words together appropriately. 2-word sentences, parallel play. We discussed that with our older age group. This is where we start to really see it start to show itself, this parallel play, where again they're playing alongside of each other, not necessarily with each other. A little bit increase in the vocabulary, knows about 300 words, walks up and down stairs with both feet. This also is where they can start getting that flu mist at 2 years of age. So keep that in mind. Up until that point, it is not recommended for this age child. Again, when we start looking at the live vaccine versus the inactivated attenuated vaccine. Let's see, about 2.5 years old, we're seeing again just a steady progression. Now they should be able to possibly put their clothes on, maybe backwards, maybe inside out. May or may not be able to button and snap and zip, but they're definitely working on this. And Should also be able to go to the bathroom by themselves, but keep in mind when we start looking at hygiene, it's a fine line between independence and allowing them to do this on their own, and then also understanding that though they can do the actions, they may not actually be wiping as well as they should be. And so for cleanliness and hygiene, they do need some sort of assistance with that. And they are able to hold up those fingers and show their age. So it's also, again, a really fun time to kind of show off your kiddo. So you will see many parents who will kind of put their child on a stage and say, tell them how old they are, show them how many fingers, show them how you throw the ball. So it is a little bit of a interesting when you get around a parent of a toddler, because odds are they're going to be showing off all these firsts that are occurring. So of course we can't do anything without talking a little bit about our theories, and here is this ego. We'll touch on it on another slide a little bit more in depth, but everything is in relation to themselves. It's all about self. This is where we get into that ego. They have some common sense and a little bit of this trial and error. If I did this and it hurt, I'm not going to do it again. This is where some of that these experiences are coming into play. And as they get a little older in the toddler phase, keep in mind at about 15, 18 months, that separation anxiety is in full swing. As we move through to the older years of toddler, 3-ish, we're going to have a little bit able to be away from their parents and understand that that parent is coming back for them and not be as afraid. They also very much learn the meaning of no. Unfortunately, as they explore their surroundings, they get into things they're not supposed to. So it is not surprising that they learn the meaning of no at this age because they hear it quite a lot. So keep that in mind, though, up until that point, that an 18-month-old may be pegged or labeled as a naughty kid, but it's really just they don't have the development to understand the word no. At age 3, we should be getting into there. And now we're looking at acceptable behaviors, how they should be acting, what is becoming right and wrong, and that plays heavily into our developmental theories. They should be able to be potty trained during this time frame. This can be a very frustrating experience for all involved. But keep in mind, just like everything else in healthcare, when we take care of people, everyone is an individual, though we give them some sort of parameters of what normal is. So you could see a child that is potty trained at 1 year, and you could see a child that's potty trained at 36 months. Again, all within normal growth and development, but again, each child is individual in what they're able to do. And again, as they grow through this phase, they become more coordinated and dexterous and a little bit less egocentric. So kind of keep that in mind. They're going to start looking at the world around them and understand that there's more than just them in it. The temper tantrums. So again, this is a little bit of a way of expressing frustration. They just don't know or have the capability to get the words and what they're feeling out. It is also a learned behavior that they are able to control situations with this behavior. So what parents need to understand is, one, be realistic in what they are attempting to do with the child. Understand that everyday stressors, basic needs are very important with the child. So we have to keep that in mind. And then how we react to the situation is also going to be a key point. So if we start looking at this, if they did not get a nap, if we changed their routine, and we haven't talked about routine yet, but routines and rituals are very important at this time. Everything else is changing very quickly. So there's going to have to be some set routines, and this keeps this world, this environment that this toddler is growing up in, and it gives them some boundaries and some stability when everything else is ever changing. So those routines and boundaries are going to be very necessary in helping provide a structure to maintain control and hopefully diminish the amount of temper tantrums. So if you keep a child up all night, you don't give them breakfast, and then you take them to Walmart for 2 hours, the outcome is probably going to be a temper tantrum, whether it's the best behaved 2-year-old or 3-year-old in the world. It's just that is going to happen because of where they're at developmentally. So what can parents do? Because it is going to happen, and it becomes very shocking, overwhelming for our caregivers when a temper tantrum does occur. Ideally, we would remove them from whatever situation is causing it. Also, we are not going to give it any more acknowledgement than it needs. So if we do remove them from the situation and put them in a safe environment, again, safety is going to be key with this. We are going to not basically give them the attention that they're seeking. And again, as we refer back up, when they begin to see that this is a way to control others, hey, kids got it figured out, right? I got a toy. All I had to do was yell a little bit. It worked for me. And it's not necessarily that they're a bad kid or it's a naughty behavior. They're just putting this cause and effect relationship together. So kind of keep that in mind. Not always the easiest thing to do for our parents, and totally understand that. So we need to make sure that we're educating our parents, telling them that if you can stay ahead of this type of behavior, support the child, have snacks, make sure they're well rested. Hey, it's not a perfect world. It's not always going to happen that way. So again, just letting the parent know it's not a sign of their parenting, good or bad. Also very important is realistic limits, which I think gets lost a little bit in what is realistic for a toddler. We talked about this when we did our school projects, their attention span and what the directions that they're able to do and keep in order is very limited. So when a parent looks at a 3-year-old and starts rattling off all of these things that they can and can't do, they lose the child. It is not something they're able to comprehend, and they're basically setting that child up for failure because this kiddo is just not going to be able to handle that. If you set just very simple, concise limits, you have a better possibility for that child in achieving those limits, as well as decreasing the frustration between parent and child. Again, rituals, routines, sleep, eating, bathing at the same time. In our house, it's bath, book, and bed. They know that. I'd love to say that it works, but again, I have a 6, an 8, and a 12-year-old, and they still seem surprised when 9 o'clock rolls around every night. So it's not a perfect thing, but you do what you can. So maybe some of you have better luck with that. But again, what we're trying to do is maintain safety and security for that child, as well as limit the frustrations that are going on with the caregiver. Oh, the stuffed animal, the doll, the blankie, these are very important items at this phase. Not as much in the infant years, but now these kiddos are starting to form an attachment with these security items. So the raggedy blanket must never get lost. The stuffed animal that gets left at grandpa or grandma's becomes a major meltdown and an emergency because they put this much attachment to the security on those items. I'm sure you can all ask your moms and dads what you carried around when you were little. So now we're looking at kind of the behaviors of these toddlers. Good luck trying to hurry a toddler along. Again, it's not that they're trying to be naughty, it's just that they're working at their own speed and trying to process everything. If you give them realistic choices, this is the same thing that we do in healthcare, isn't it? We are going to take away all your control or limit what you are able to do, but I'm going to give you options. You can either shower before or after breakfast. This is what we're going to be doing, the same type of mentality when we deal with a toddler. Also, don't expect to tell a toddler go to bed and that it will occur at that exact moment. Many times a better option is to say you will be going to bed in 15 minutes. Now they don't know what 15 minutes is, but we've already put that idea in their head. It's going to be 10 minutes now. It's going to be 5 minutes. So again, we're working our way into that. They say no to everything. A lot of it is just repeat. That's what they've been hearing a lot, so they're able to say that back. And some of it is that they aren't really aware of what they can and can't do. So again, it's going to be no. What our goal is to again help them feel secure and in control of what they can and can't do. Sibling rivalry is very interesting. This is usually if there's toddlers in the house, this is kind of when families are being formed and brothers and sisters are coming into the picture. As much as you can include this toddler in this process, it's probably going to be a little bit easier transition because now they're looking at everything's changing. Mom and dad's attention is now shifted and their world has been kind of flipped upside down. And as we see from our temper tantrums, they don't know how to do this. They don't know how to handle these changes and express it in a positive manner. Even if you bring a new baby home and you have a brother or sister who absolutely loves that baby and wants to be a part of it, and it is encouraged that you allow that toddler to be involved in some of the cares of that child in a safe environment. Don't ever leave a toddler alone with a newborn for just safety reasons alone. They just don't know what can and can't be done. So they may unknowingly do harm to this child. I remember very distinctly how Natalie was very proud of herself for giving Owen a fruit snack when Owen was about 6 months old, which was not an appropriate food group for poor little Owen. But she was really proud of herself because she shared with her. They're about 18 months apart, so Natalie would have been right about 2-ish. And so little eye open, we got the fruit snack out of Mr. Owen's mouth, but again, just a sister being very helpful to her little brother and feeding him some fruit snacks. Whoops, again, I am more than happy to share my less than stellar parenting techniques here. So here we have just a nice picture of kiddo, again, safely being supervised while helping. Oh, discipline. So I think this is kind of an interesting conversation. Consistency is key. It falls into rituals and routines. If I do this, this is what's going to happen to me. If you start saying, if you throw that ball at your brother, you are never going outside again, well, that's really not going to be something that is consistent and or be able to be enforced. So we want to make sure that it's something within that is appropriate and that we can actually follow through with. This again with those temper tantrums, same thing with the discipline. If they're doing something wrong, ignore the bad behavior. In theory, they should stop doing that behavior. Again, you may have to remove them from a situation if there's some sort of safety concerns. We want to reward appropriate behavior. So if you do see them doing something right, again, they're hearing a lot of no's. You can't do that. Don't do that. Don't touch that. Put that away. Take that out of your mouth. So if we can make sure that we are telling them and acknowledging when they are doing something good, then they're just going to want to keep doing that. Rule of thumb, timeouts 1 minute per year. After that, it's very ineffective. So if you have a 3-year-old, you're going to have about a 3-minute timeout. This is what I think is a little bit interesting, and everyone's going to have their own view on this. When you see corporal punishment, again, this means spanking. And again, I'm not here to solve that question, but just understand that everyone has a little bit of different view on this. And a lot of us use, or you may use, or you will hear said, well, my mom did it. Well, my dad did it. We have a very public, publicized um, occurrence with the Adrian Peterson story. I think that was what, 1, 2 years ago. And his argument was, well, that's what I grew up with. And so that's how I discipline my kids. So just kind of keep that in mind. Um, that it's a very touchy subject. Again, sharing a little story, we had Cole would have been about 18 months, and we went to Pizza Ranch, and he was, I don't even know, screaming, crying, throwing pizza across the table, maybe all of the above. And I remember Rob picking him up. He was wearing diapers, swatted him on the butt, didn't think much of it, right? And took him out into the front lobby, removed him from the situation. Again, I'm kind of looking around and I see this woman who is just glaring at our table. And it dawned on me, she was very, very upset that she had witnessed Rob swatting little Kohler's butt. And I can tell you now it wasn't a hard spank. It was a tap on the bottom to get his attention, and out we went, and I didn't really think anything of it. But it was really eye-opening to me because, again, I know that's what his parents did. That's what we did. And, first kid, so we didn't really know what the heck we were doing anyway. But, again, just kind of keep that in mind when we're counseling our parents and caregivers on corporal punishment, yay, nay, this and that. Just know that parents need to be very mindful that they are doing it to actually discipline the child and not as an outlet for their frustration. And that becomes a really hard line sometimes for our parents when they're in these situations. And that's where you can start to see this corporal punishment move into more of an abuse situation. So it becomes very sticky. And I don't know if I have a really good answer for if a parent asks you, should I spank my kid? I don't know really what you would say to that. So that would be a really interesting conversation to have with possibly a pediatrician, and it could very well be based on doctor to doctor. So that ties in a little bit with what's the goal of the discipline is basically to stop bad behaviors, promote good behaviors, and give that child the skills to be able to control themselves and maintain the good behaviors, right? I mean, that's really what we're trying to do so that they don't act like a 3-year-old when they're 6 or when they're 9 or when they're 18, that they have this self-control and self-discipline. And what I think is also really important is that we're doing this without losing that sense of self-esteem. We are addressing the behavior, not the child. And this gets, again, very hard when we start looking at labels. And this is the bad kid, this is the naughty kid, this is the kid that gets in all the trouble. And now this becomes kind of a self-concept issue with that kid. So, Freud, this deals with, again, the ability to potty train at this age. They are becoming to understand that they have the power over their bodily habits, fluids, emotions. They're able to hold on when they want to and let go when they want to. So that ties in very much between Freud and if you want to apply it to bathroom training, toilet training. Erickson is autonomy, which is again that self-independence, self-monitoring versus shame and doubt. And so he's looking at himself in the environment and is saying, am I able to fit in this environment on my own? I can control what I do. Look at what I did. Look at this new thing I can do. So again, depending on the feedback from those around him is going to be if we foster this autonomy or if we foster shame and doubt. Again, we start looking at it is a really hard time to parent. Again, very exciting, but it can be very hard. And I read somewhere that A lot of a child's fastest growth and development occurs within the first 3 years. So these are really impressionable, important years for this kiddo. This is all a little bit repeat, so just going to keep on moving on. Piaget, again, we're looking at cognitive growth. Trial and error, again, that's going to be where they start saying, hey, cause and effect. If I do this, this happens. Whether or not it's necessarily an appropriate cause and effect, they're going to start piecing that together a little bit. The classic game, drop a toy off the high chair, right? If I drop it, mom picks it up. Fun game, if I drop it, mom picks it up. And then they're further exploring this object permanence, which is, again, that idea that if things leave their view, it doesn't mean they disappear. It's actually still there. And let's see, very much pretends, imitates, role plays, wants to be just like big brother, is going to imitate them, or dad, mother. This is also no concept of sharing. So this idea that your child is going to go to a play date or in preschool and be able to share, we are continuing to promote this behavior and will reward it, but they really don't understand this idea that they should be part of helping someone else, because again, they're so egocentric, so it's very self-involved. It's all about the P's here. If you want to put this on a flashcard, I think it's a great way to figure out what a kiddo at this age should be able to do. Push, pull, pedal, looking at the tricycle there. Play-Doh, form things in that Play-Doh, paints, puzzles, and pegboards. I am going to put a link on under your bookmarks on TigerNet. It's a 10-minute video that does a wonderful job of following little toddlers around and a voiceover of the different milestones. Again, it's 10 minutes, a really good video, so I'll make sure and upload that for you. We talked about that cause and effect. Kohlberg's, the moral development, right and wrong, good and bad. So again, this is where we have to be very mindful that we're addressing the child, that the behavior is bad and not the child is bad. And that in their limited view, this cause and effect can be a little bit distorted. So it's hard for them to grasp that if they did something and they get yelled at, that it's not necessarily that they're a naughty kid. And again, they're imitating, they're helping, they're wanting to work around the house. So they're looking for that reward, that praise, that acknowledgement of something good that they did. And all of these kind of developmental theories, luckily, they don't battle each other. So when we look at Fowler's spiritual development, again, it plays into that, that they're going to be role playing or imitating those around them. So it's really quite the cutest thing in the entire world when you see a little 3-year-old who put their hands together to pray. But it's not necessarily that they're understanding that what their action means or what they're representing. It's just that they're able to imitate that, and that is a foundation of this spiritual development. And again, depending on what culture or religious beliefs that you follow. But again, they can't put the greater meaning behind what they're doing. They just think it's fun because everyone else has their hands together and their head down. Well, they can do it too. We talked about this a little bit, so I think you can go ahead and take a look at that. This is a big thing where they don't want to see things, so they want a Band-Aid over everything. Keep that in mind. That's a little bit of an individual for each kiddo. This is going to be where if you have to put an IV in or do a shot, a lot of times what I hear and what I see in practice is don't watch, look over here, don't watch, or they'll cover their eyes. Some kiddos have to see this, and it's a bit of a control thing. So they want to be able to see what's exactly happening, because that fear of not being able to see it is almost worse than actually watching the shot. So keep that in mind. That's just what I've noticed in practice. Overall, though, Once that shot is done, they want a Band-Aid over it. The IV that's in a kiddo on a toddler, you're going to be wrapping up with some fun color because, again, when it's covered up, that means that owie is all gone or it's getting better underneath that Band-Aid. My one disclaimer, I want you to remember when you have an IV in a toddler, make sure that you're securing it appropriately and get specialized training in that when you do, if you do work in a peds area or have to put IVs in pediatric patients. But we love the fun printed Coban. It's just a great thing at the hospital because it makes our kiddos happy. However, what I see is that we wrap that Coban all the way up to the fingertips, basically from the elbow to the fingertips. Everyone's happy, but you cannot see that IV insertion site. Leave yourself a window so that you can come into that room, look at that IV site, whether it's on the wrist or the arm or elbow or wherever, and be able to see if it's red or infiltrated. Otherwise, you have to touch that arm every time and unwrap it. Even worse, and I do see this, is that people don't even do that. They just look and see if the pump's running okay, and then they count that as assessing the IV. When underneath all of that Coban, there's a really bad infiltrate. And toddlers are squirmy. They move. It's so even as much as you tape and tie down and put a board, you have to be very diligent in your assessment of that IV. So that's just going to be my little soapbox for that, IVs and toddlers. And I'm looking at this, so really what they're looking for in a toddler, they want and need that discipline, boundaries, routine, but they also want to know that if they stray, if they have a tantrum, if they lose control, that doesn't mean that love gets taken away from them. So really security that's where this comes into play as well, that things are changing. So this blankie is going to help me kind of anchor me here. And I know my mom and dad love me, but that doesn't mean that when they're tired, they're not going to throw a tantrum. So just kind of keep that in mind with these kiddos. No speech by the age 2 to 3, need some sort of speech referral. Ironically, you may not believe this, but I was actually referred to a speech pathologist when I was 3 because apparently I didn't talk very much, and I have done my darndest to make up for that. So obviously there was nothing wrong there. But basically by 3 you should be, again, up to 300, some say even 500 to 700 words, and be able to have some sort of sentence formation. Otherwise, there could be some cognitive and or other sensory issues that you need to look into. Elimination control, we talked about that a little bit. It does have to do with innervation of the urinary tract and the GI tract on being able to control the voluntary and involuntary muscles. I know we talked about this last year when we looked at considerations in fluid and electrolyte and elimination, fluid and bowel elimination. So if we're looking at a guideline for what to tell our parents, really this child should be able to walk for 1 year and be able to follow some sort of instructions, simple instructions, and really stay dry for at least 2 hours before it would be even worth the parent's time to attempt to potty train. Oh, food considerations with our kiddos. This gets to be a little bit tricky. They can become very picky eaters. Their appetite decreases because their growth rate decreases. So this can be very confusing for our parents as well. They ate the baby food peas, they love them, and now they won't touch the peas on their plate. Or they would drink a whole 12-ounce bottle and eat a baby food, and now they're eating 2 bites of noodles and saying that they're full. So our recommendations for these parents and caregivers during this developmental section of this kiddo's life is just to offer them healthy, nutritious snacks often. 2 snacks and 3 meals is ideal, but if they're not going to sit down and eat at that meal, then it may be that you're going to just go ahead and offer them snacks throughout the day, but making sure that they're quality um, calories versus just a filler. So again, not always the easiest thing to do because they do become a little bit picky eaters. This is the age group where you will hear all my kid ate from the age he was 2 to 4 was mac and cheese. That's all he would eat is mac and cheese and peanut butter jelly. So you are going to hear these stories because they do become very picky, and again, it goes into routine. They would only eat with their Lightning McQueen spoon, and if they didn't bring the Lightning McQueen spoon to the restaurant with us, the kid wouldn't eat. Again, it's not that the kid's trying to make our lives difficult, it's just that they're that ritualistic and in routine, and again, that makes sense to them, and so you will see a parent pulling out the Lightning McQueen fork from their purse at the restaurant. Trying to see here, I think you can go ahead and follow that okay. Poisonings is where we will cover this information after our public service announcement, so I'm going to flip through that quickly. Immunizations, we talked about this a little bit and talked about that case study, so do review that. And then we start looking at infectious diseases, which I think we'll go ahead and save that as well. And we can go over those here. I do want to spend some time on meningitis. I know one of the students asked in class about the amount of questions that are on meningitis on this test. I did review the test. I do think I'm going to take a couple off. So I believe it was 11, I'm guessing, I don't have the blueprint in front of me, questions on meningitis on this next test. And that might be high. But anyway, I think I'm going to take 2 to 3 off. And so kind of keep that in mind. But my recommendation to you is, again, pull out your pre-simulation work packet and review that meningitis. For those of you that have had that sim, I will remind me and I will hand those back to you so that you're able to use those as study guides. It has wonderful information about bacterial meningitis in there and some great questions that you can use as a study guide. So if you haven't filled that out, this is going to be a nice reason to go ahead and do so. So meningitis can be caused by, well, let's break it down. You can have bacterial meningitis and viral meningitis. Viral meningitis is not as life-threatening as bacterial meningitis, and it's very symptomatic treatment. So you're going to be giving them symptoms or medications and interventions to treat the symptoms. Bacterial meningitis, and sadly at our campus we know how life-threatening this disease can be, is a life-threatening medical emergency. There are 2 organisms that can cause meningitis. The worst, that's such a horrible word, but I would say the most common and probably the most aggressive is this Neisseria meningitis. And it's very much in group live environments. So think about small confined areas, dorms, daycares, military camps, athletic teams, spend a lot of time in locker rooms and on buses together. And so again, you're looking at kind of this group living can breed and foster and spread this type of disease. So what you're looking at if someone does test positive for meningitis is it's spread through droplet. So that's another thing to keep in mind, is that shared water bottles, again, a lot of the meningitis cases that I've heard of or been a part of all had to do with athletic teams. So all of those water bottles that all get kind of thrown together under the bench. Think about in daycares, the coughing, sneezing, or even in a school setting. So droplet isolation is what you're going to be used for 24 hours after antibiotics are initiated. Another thing, anyone who has been exposed, once it's been confirmed, needs to be seen, and the doctor will recommend prophylactic antibiotics. So that's also something to keep in mind. I'm trying to think. I know I was exposed at one time when I was working in a hospital lab, and I was given Cipro, but there are other antibiotics that you may or may not be given, like rifampin might be another one. So prophylactic antibiotics for anyone who has been within contact of this child, and that includes healthcare givers. Here's that H flu meningitis, another cause of it, is rare because, again, we have that immunization for it. I'm trying to kind of pick through the slide here. So in pathophys land, if we're going to walk it back that far, meningitis is an actual inflammation of the meninges. Meninges are those 3 layers that lines the brain, and so that becomes inflamed. And it's the brain and the spinal cord. So our most definitive diagnosis, we're going to have tons of assessments, subjective and objective, but our most definitive diagnostic test for this is going to be to see the actual bacteria in the CSF. So if we're looking at CSF, we have to think, how am I getting that CSF? So the actual process is through a lumbar puncture, or an LP. So these patients will have had an LP. This CSF would have been collected. They're going to look at it. Is it cloudy? Is it clear? Was there pressure? Was there not pressure? They're looking at it under a microscope. They're analyzing it in the lab. Is there glucose high or low? Is there protein? Is there white blood cells present? But what the doctor wants to know is the gram stain. So you can thank Dr. Mulliken for telling you all about that. But what that lab person in microbiology is doing is putting some of that CSF on a slide, doing a gram stain, and looking at it under a microscope and identifying this bacteria. That is your definitive diagnosis for meningitis. But again, there's going to be a whole slew of signs and symptoms. Some of them are going to be very vague. And then I know you guys just got done with your neuro unit, so you also have 2 very specific tests that you're going to be using as well. You're looking for positive signs of the Brudzinski's and the Koenigs. So I'm not going to go over how to do those, but please review that because that is something that ties in with meningitis. So we're looking at someone who's greater than 2 years. I can't say that you wouldn't see it in someone younger than that, but it would be highly unlikely. You're going to have all the signs and symptoms of increased ICP, intracranial pressure. So put that in your little Rolodex in your brain there and start flipping through. Okay, all the signs and symptoms of ICP can also be present. So keep that in mind. Vomiting, lethargy, high-pitched crying. When we deal with some of our younger population, this very high-pitched cry is going to be a sign of some sort of neural issue, including meningitis. And kind of this periodic sucking. With ICP, we have to remember that it can interfere with all of our cranial nerves. So we have to keep in mind of, okay, of the cranial nerves, I'm trying to think of the right word here, what deficits maybe, what might I see? So this is where we get into that photophobia or papillary edema, all of these things that, again, are signs and symptoms of that increased ICP. And then seizures. Now, this could happen in someone who's never had a seizure, and this doesn't mean that they have a seizure disorder. We are going to be doing a lot of interventions to help prevent a seizure because, again, with seizing, we run the risk of increasing ICP. So here's our Brudzinski's and our Koenig signs. This is telling us that there's some sort of inflammation or irritation. Here's some great signs and symptoms. How is a 4-year-old going to tell you if they have a headache? So just kind of keep that in mind when you're looking at how are you going to be doing some of these assessments. Um, they're going to be a little bit more comfortable lying than when held, but this is going to be really hard for this kiddo because they want to be held. Because again, they have this fear of losing control, they don't feel good, they want their mom or dad to be holding them. You're going to be assessing LOC and seizures. A spinal tap is the same thing as a lumbar puncture. They're also going to be doing an LP, lumbar puncture, after treatment, about 7 to 10 days after antibiotic therapy. They're going to be looking in that CSF and making sure that there's no longer the bacteria present. And they're looking here we're looking at CSF sugar, normally 2/3 of a serum blood sugar. So what we're saying here is bacterial meningitis. First, I have to differentiate. You will be testing the glucose level within the CSF. This does not mean it comes from the blood. So those normal ranges that we talk about in glucose and our finger stick blood sugars, that's not the same sugar or glucose that we're looking at. This is specific to the amount of sugar that's circulating in this CSF. In a bacterial meningitis, the glucose in the CSF goes down. Again, it's because it's a bacteria. That's what it's eating. So you're going to see low sugar, not low blood sugar, but low sugar in the CSF. You'll see an elevated WBC in the CSF. Again, make sure that you're understanding that. And also an increased protein in the CSF. Because again, it's bacterial. Bacterial has waste products. It increases the amount of protein in our CSF. And then ICP. Antibiotics is going to be the one thing that this patient needs, and this gets very hard, and we talk about prioritizing, and this becomes when you're looking at it going, I'm going to be doing all these things all at once. I have a 1A, I have a 1B, I have a 1C, because they all deserve to be at the top of the list. But remember, until we give them antibiotics, all we're doing is treating symptoms that are going to get worse. The antibiotic must be initiated in order to kill the bacteria that is causing the meningitis. And then it has to make sure that you're using the appropriate antibiotic. Another sign and symptom has this purpura. I mentioned that the teenager that I took care of who had this petechiae all over his body, he looked like a Dalmatian, he really did, with these purple spots. Again, and this was a sign of this progressing meningitis. So how are we going to be taking care of them? Well, one, we're going to be safety. So we're going to be monitoring for seizures and have seizure precautions in place, obviously because of the inflamed meninges and the increased ICP. So go back to that neuro unit that you just had. You haven't thrown those notes out yet. Start flipping through all of these signs and symptoms of a neurological disorder. They're very much the same. And then let's see here. You should see if they are responding well, that they're going to have decreased temperatures, no seizures, increase in LOC, and that is a good sign. I will tell you what happens is that as this bacteria progresses in meningitis, you get down into a very much of a shock, a septic shock, where you will see people who will lose fingers, legs, have some sort of failure because of, as a lasting side effect of meningitis. And that was, again, the teenager that I took care of. He lost several fingers, part of a leg, and had kidney failure due to the meningitis, but he did live. So again, the treatment was effective. It's just that serious of a disease. So looking at, again, what we're going to be doing for them, we're going to be supporting their respiratory. Remember, we're going to be managing their airway. As their LOC goes down, their Glasgow Coma scale goes down. You guys all know this. when it's 8, intubate. So I think that's a really great little rule of thumb. So though that airway support it has nothing to do with the pathophys of meningitis. It does have everything to do with the symptoms of that neural interruption and the patient being unable to manage their own airway. And we want to be able to be assessing that and be able to intervene as quickly as possible before things get out of hand. IV fluids may be initiated because of low blood pressure. Vasopressors, again, to help stabilize and enhance blood pressures. Decreased stimuli, quiet environment, limit your interruptions if you can. And then we're also going to be absolutely managing. These patients become tricky, and I know you talked about this with neuro issues. Meningitis is the same. And we can't just throw a bunch of fluid at the problem, which is what we do with a lot of our issues, and it seems to correct. We want to be sure that we are not aggravating that increased ICP. So we want to make sure that we're watching for that. And let's see. Here we see that, again, that rifampin for close contacts or exposures. So maybe highlight that, kind of keep that in mind as a prophylactic. The other one that can be used is Cipro. So keep that in mind too. What's unique about rifampin, and we do want to make sure we're educating about this, is that it comes out as an orange secretion, so it may be in their urine, their tears, so their contacts may be stained orange. So that would be something that would educate them specifically if they were prescribed rifampin for an exposure. All right. Well, that was kind of meningitis in a nutshell. Absolutely, I want you to review this and come to class with questions. So whatever growth and development or meningitis, make sure that you're writing down any questions that you have. And we do have class time this coming Wednesday that we'll be able to go over that. And I know we're going to have plenty of time to address everything that day. So I think that will be great. So that is all I have. And again, email me if you have any questions. Otherwise, I will see you on Wednesday. Thank you very much.